All right, so now we're going to talk through what we do with medications when we have AKI. So we know that AKI is going to change a few things. For medications that are renally eliminated, it's going to decrease the renal elimination. And then something that's maybe not quite so obvious is for hydrophilic drugs. If the volume of fluid in the body is different because of AKI, it can alter the volume of distribution if it's hydrophilic. Again, it's probably more obvious that if something is nephrotoxic, we don't want to use it in AKI. Maybe less obvious to think about the fact that if medications accumulate, they can potentially cause injury somewhere else. So we're not always holding or discontinuing a medication because it is nephrotoxic, but sometimes it's actually toxic to other parts of the body, but it accumulates in renal impairment. So if you want to just leave this slide up for yourself, but then also open Lexicomp, we are going to actually, for each of these medications, look at Lexicomp together. The sections in particular that are useful to try to help us figure out what we should do with this medication in AKI are the indication, just to figure out what the medication is used for, renal dosing, adverse effects, and pharmacokinetics. So let's start out with metformin. So metformin, we already know the indication. The most common one is going to be diabetes. If we think through how does it work, so does it acutely change glucose levels or is it over the long term? So metformin is an insulin sensitizer, so it's not going to acutely change glucose levels. I mean, like it's not going to affect it based off of the last couple of minutes or the last couple of hours, whereas if we give insulin, that's a very prompt change. When we go to renal dosing, dun, 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 renal dosing. So we can see that, okay, there are recommendations for what to do in renal impairment, and in fact, it's contraindicated if creatinine clearance is less than 30. So if we have a significant case of AKI, we have no idea what creatinine clearance is. We can't calculate it. So we're safest to assume it's less than 30. Next section, I said to look at adverse effects. So there's not a section just called adverse effects. So I usually look at warnings and precautions. It says avoid in severe renal failure, avoid in metabolic acidosis. Warnings and precautions, we have lactic acidosis. So this is generally the reason why we want to avoid metformin in acute kidney injury is because of the risk of lactic acidosis. This is potentially life-threatening. Here it's saying in renal impairment, metformin is substantially excreted by the kidney. Elderly, use with caution. Risk of metformin is associated with lactic acidosis. Contrast media, we'll talk about this later, but radiocontrast media is one of the medications that can, or it's not necessarily a medication exactly, but it is a contrast that goes into the venous system, and it helps when you're taking like an MRI, it helps the images come out better. So with this contrast media, it's recommended to temporarily discontinue at the time. So there's a lot of clues there that if we have acute kidney injury, we should not continue metformin. We should hold it. Holding is generally something that we talk about in the hospital. We usually say a lot of times hold outpatient medications while they're admitted. If you're in an ambulatory care setting, you kind of have to decide how long you want the patient to hold it. So let's say a patient comes into your clinic, you think they have AKI, you might say, hey, don't take the metformin until I can get your serum creatinine a week from now and see if it's normal. If it's normal, you can start it again, but don't take it until I know that it's normal again. I think that's all we really need for metformin. Let's go to another one. Lisinopril. Lisinopril. All right. Lisinopril, we know it's going to be for cardiovascular things, for hypertension, or for blood pressure. Another kind of chronic thing, right? We're not necessarily using it for acute hypertension, we're using it for chronic management of hypertension. There is some dosing considerations in renal impairment, but you can see they're kind of loose, right? They still say that you can give it at a max of 40 milligrams per day, which is already our normal maximum. So Probably not too big of a deal. Let's look at, what's the next thing? Adverse effects. So kind of have to go through to find some. Safety issues, maybe. Nope. Contraindications. I don't see anything there. Concerns, angioedema, cough. Hyperkalemia. Okay, so if our patient had hyperkalemia, which you can get with AKI, we need to avoid it. Hypotension. Ooh, renal function deterioration. Maybe associated with deterioration of renal function and or increases in BUN and serum creatinine, particularly in patients with low renal blood flow. So what is low renal blood flow? Hypoperfusion, right? Pre-renal injury. So if somebody has pre-renal injury and they need angiotensin II, you could potentially make that pre-renal injury worse. So if you need the ability to use RAS, your lisinopril might actually block your body's ability to use RAS. It's kind of buried in there. Let's see if we see anything else. Don't use it in renal artery stenosis. So that's not necessarily AKI, but here we have the renal impairment again. Use with caution and pre-existing insufficiency. Yeah, so if you have pre-existing renal insufficiency, AKI is probably more insufficient than what they're usually going for here. They're probably going for just a decreased creatinine clearance, but this is saying that we should avoid escalation of the dose because it could lead to further renal impairment. So this one is definitely something that we should avoid in AKI because once again, it's something that we use chronically for hypertension. We use it chronically to decrease chronic kidney disease. It's good in the long term, but during AKI, it can just take the situation and make it worse. Let's see our next one. Levothyroxine. I don't think you guys have had endocrine yet. In fact, I know you haven't. But levothyroxine is something, again, that we use long-term to keep our thyroid in check. You can see that hypothyroidism. Used for hypothyroidism. All right. Next, we want to look at dosages. Hypothyroidism. There's no renal impairment dosing, so that's good. So maybe we don't have to worry about it in AKI. Let's not stop there though, just in case. Let's go, because there's no renal dosing, I'm going to check real quick on pharmacology and pharmacokinetics. I'm looking for excretion in the urine. Okay, so it is eliminated in the urine. So that's something to think about, but it is metabolized prior to then. And so the effects of levothyroxine are going to occur earlier, and then they're going to affect basically our hormones. And so levothyroxine, because the effect is not directly tied to how much of it is in the blood at a given time, it's not going to be as big of a deal. And it takes quite a while. It says peak therapeutic effect may require 4 to 6 weeks. So overall, it's going to be pretty safe to continue levothyroxine. It takes a while to make these hormones change. It may be something that you'll need to monitor TSH more closely if they're having AKI, but I didn't see anything big there that made it like a red flag. I don't think it said it was very hydrophilic, did it? Yeah, it's mostly protein bound. So overall, it's something to think about if the renal impairment is really severe, but it's not going to be something I'm going to worry about. Even within a week, maybe even 2 weeks, I'm fine with continuing to levothyroxine. Let's look at ketorolac. What is ketorolac? All right, something for pain. Just tells us it's for pain. So let's see what it actually is. Pharmacology. Okay, COX-1 and COX-2 inhibitor, so it's an NSAID. NSAIDs, we probably already know, cause acute kidney injury. So is it nephrotoxic? Yes. Then we don't want to continue in acute kidney injury. So that one's going away. Enoxaparin. It's for DVT prophylaxis. It's given subcutaneously. Let's just look real quick at pharmacology, see what it is. Okay, so it's like a heparin. So, dosages, renal impairment. All right, so we do have some doses changed if creatinine clearance is decreased. So if creatinine clearance is decreased, which we assume it is in AKI, we don't know how much because we can't calculate creatinine clearance. It's telling us that we need to use a decreased dose. Let's look at adverse effects. Bleeding. Hyperkalemia. Thrombocytopenia. So yeah, the biggest thing here I would say is if we give too much of this, so if we give it and the kidney isn't clearing it, we potentially risk a bleed. Use special caution in the elderly because of delayed elimination. Yeah, that makes sense. Usually if it's delayed elimination in the elderly, it's because it's renal. Yeah, so basically we do not want to use enoxaparin in AKI. We would try to use something else, perhaps heparin. Morphine, levofloxacin, acyclovir, and vancomycin. Morphine. Morphine, I'm sure you guys know, is an opioid. Let's look to see if it has renal dosing. No specific dosing, but it does say to use caution. Let's keep going. We know the adverse effects, it's an opioid. We don't need to look that up. But let's just look at PK. Biggest thing I'm looking for is urine. Excretion, urine. Primarily is this 3% to 15%, 2 to 12% unchanged. That's a fair amount. So it's not like 100% renally eliminated, but let's say if 10% of it is, and you're giving a lot of morphine, you potentially risk an overdose. So it's something, maybe we're still going to use morphine, but we may use a little bit lower dose than we might otherwise, and we're going to monitor a lot more closely for symptoms of respiratory depression and things like that. If it's an outpatient medication, we may not want to use morphine long term. I'm more thinking if it's an inpatient medication, we really want to monitor for respiratory depression. If it's an outpatient, we'll probably, maybe if we can find another opioid that's not as renally eliminated, that might be better. All right, levofloxacin. Levofloxacin. It's a fluoroquinolone. Okay, so we know it's an antibiotic. Let's look at dosages. Renal. Okay. We need to adjust it if it is fairly, oh, this has a even just 20 to 49. So it definitely has renal dosing considerations. Let's look at PK. I want, ooh, really highly renally eliminated, really highly renally eliminated. So this is potentially can accumulate quite a bit. Let's see what could happen if it accumulates. Adverse. Okay. And I just know that this one has a black box warning, so I'm going to go back up here. All right, QT prolongation, glucose regulation, hepatotoxicity, hypersensitivity, phototoxicity. potentially an irreversible tendonitis and tendon rupture, peripheral neuropathy, and CNS effects. Superinfection. Use caution with renal impairment. Okay, so this is one because it's an antibiotic. If it's the one the patient needs because it's the only thing that's going to treat their infection, they may need to get it anyway in acute kidney injury. But we know we've really got to monitor hard for these side effects, and we're probably going to want to use a decreased dose in AKI. What dose should we use? That part's a lot harder. So if you have some baseline kidney function, you can kind of guess how much their kidney is impaired. But it could potentially be a crapshoot, and you kind of just have to try something and then see if you think they're having any of the toxicities. The biggest thing, though, is if they're having an infection and they have AKI, it's possible that infection is causing the AKI. So it still may be worthwhile to treat them with the fluoroquinolone, because if you get rid of that infection, then hopefully the AKI should resolve. Okay, acyclovir. Oh, can't type. Acyclovir. Acyclovir is an antiviral. See if it has renal dosing. Yep, quite a bit of renal dosing considerations. So we know it does need to be, we need to look out for it. Let's see what can happen. Warnings, neurotoxicity, that wouldn't be good. Extravasation, that's more of if it leaves the vasculature after you give it. But renal effects, sometimes fatal. Nephrotoxic. Okay, so acyclovir is something that would be much more dangerous in AKI. So we're really going to have to think about risks versus benefits. A lot of our antivirals, though, are very similar to acyclovir. So this is one that's going to red flag us, but it's not an easy solution. Acyclovir in particular is good to remember because a lot of people use it chronically for HSV, for herpes simplex virus, and they may start it when they're younger, and so nobody's thinking about the fact that they're getting older and their kidney function is decreasing. So acyclovir, they may not adjust the doses, but they actually need to because the kidney function is decreasing. So that's one to keep your eyes on and remember about. And then we got one more to look at, vancomycin. Vancomycin. All right, dosages, renal impairment. Gotta monitor patients with renal impairment. Oh yes, and vancomycin is actually dosed based off of renal function. So the kind of bad thing about this is we don't know what their creatinine clearance is because they're an AKI. So we kind of have to guess. If we think that they're having really severe AKI, like their kidney's not working at all, which I've had some experience with that with people in the ICU where the kidney is not working at all. What we do is we kind of follow our, let's see, here we go. We kind of follow this one. We assume if their kidney's not working at all, they have a GFR of less than 15. So basically you give a dose and then you check their level after 24 hours. And if it's less than 20, you give them another dose. So really you're just checking a level, seeing once the kidneys finally started clearing some of it, and then you can give another dose. A lot of times though, people who have AKI, their renal function is still going. So then you might just dose it based off of whatever creatinine clearance you calculate for them. Again, knowing that's not going to be an accurate calculation, but you got to go with something. And then let's say that your calculation gives you 45 mils per minute. Then you might dose it accordingly. The nice thing about vancomycin is the drug levels are easy to get, and you don't want the drug levels to get too low or too high. If they get too high, let's see what can happen. So I want to go to warnings and precautions. If they get too high, we can have nephrotoxicity, so that's not great. Ototoxicity, potentially neutropenia. So if our doses get too high, we can kind of fry our kidneys, fry our ears. So we don't want to get too high, but if it gets too low, we might not treat our infection adequately, and it could be the infection that's causing the AKI. So with vancomycin, the solution is really using a dose that we think will be enough to get their serum level high enough to treat the infection, but then checking a trough or checking a level of vancomycin to see where they're at, to see when they should get their next dose. Okay, so that wasn't every medication possible, but that was a good range of medications, and you can see how you use LexiComp to try to answer some of those questions. Let's see what's left in this presentation. So when we talk through general strategies to prevent future AKI, which should always be a thought if the patient's had it before. First off, how do you know if AKI is resolved? The biggest way you're going to know is if serum creatinine has returned to baseline. If the serum creatinine is back at baseline, you can resume maintenance meds. Unless you think that medication is what caused the AKI, then you may choose to avoid it. Some meds that you should ensure are not continued would be NSAIDs, or something if it caused acute allergic interstitial nephritis. We don't want to start that again because we don't want them to have another allergic reaction. Luckily, if it's something like, let's say, lisinopril, we know it's good in the long term. So once the AKI is resolved, we can try it back on. We might try at a lower dose, but it's still going to be worthwhile to start it back up again. Let's say your patient was admitted to the hospital and their AKI isn't resolved because their serum creatinine hasn't returned to baseline, but they're ready to go home. You've really got to think about when should the patient resume their maintenance meds. If you, the pharmacist, doesn't go talk to the patient, how are they going to know what to do? And also think, who's the next provider they're going to see, and what can you do to set this encounter up for success? So I would say the biggest thing would be telling them to hold anything that I think is going to be nephrotoxic or dangerously accumulate. Make sure they know not to take those for now, and then to call their primary care physician so that they can find out pretty quickly what they may need to resume. Anything that we held that's for chronic diseases, it's probably not going to be an emergency when they go home either. So let's say they were a metformin. They were somebody who's admitted with metformin. I'm fine if they don't take their metformin for another week or two. Their PCP can start it back up when they have time to see them. It's not a big deal. Thinking about diseases that increase the future risk of AKI. So again, any disease that's going to hurt the kidney, like let's say heart failure, because you're not necessarily getting adequate blood flow to where it needs to go. And any disease state that requires nephrotoxic meds. So if you think like rheumatoid arthritis, a lot of times people need to take NSAIDs for that. But that disease state is, or the medications for that disease state are making kidney disease worse. So that's going to be somebody who's more likely to get AKI in the future. A really good way to combat that is to avoid dehydration. So make sure they're maintaining adequate hydration and drinking plenty of water. Some other specific patient factors outside of disease states, if they're older, and by older I mean like 70s, 60s is where it starts to get a little bit riskier, but if they're 70s and beyond, their risk of acute kidney injury increases. Part of that is because older adults have less total body water, so the older you are, the easier it is to become dehydrated. Lifestyle, if there's somebody who runs marathons, much higher risk of AKI, or if there's somebody who has a propensity to use a lot of NSAIDs, much higher risk of AKI. My NSAID use one again. So the biggest thing is patient education, avoiding NSAIDs, drinking lots of water, and overall just trying not to become dehydrated. All right, that's it.